I want to tell you a little bit about disorders of primary hemostasis. Generally, these disorders present with common symptoms, and that's bleeding of the mucosal surface. We have epistaxis, which is in another word nose bleeding. We have GI bleeding. We have hematuria, menorrhagia, and in severe cases with severe thrombocytopenia, we may have intracranial bleeding. So when you see a patient with severe thrombocytopenia, you have to think about intracranial bleeding occurring because of severe thrombocytopenia. Now, when we are talking about ischemic bleeding, normally we have these three formations of ischemic bleeding. The first one is petechiae, and you can see it here. This is the smaller forms of almost rash-like appearance it has. The second one is purpura, which is a little bit larger, and the last one is ecchymosis, and they are larger than purpuras. Now, patients with this happens normally due to thrombocytopenia. Also, people who are suffering from disorders of primary hemostasis, they may present with easy bruising. Now, here you can see some of the symptoms. Here you can see petechiae or purpura and ecchymosis and bruising and other sorts of primary hemostasis symptoms. Now, lab studies you can perform for the patients who are suffering from primary hemostasis is platelet count, and normally platelet count in these patients is lower than normally. Normal amount of platelet is 150,000 to 450,000 platelet per microliter. The other things you can study in this patient is blood smear. You can look at their platelets to see if they have the normal shape and normal count, of course. And the other one is bleeding time, and now this is not used in clinic anymore, but normal bleeding time is 2 minutes to 7 minutes. So anything below that can be an indicator of primary hemostasis problem. The other one is bone marrow biopsy, studying megakaryocytes. For example, if you see in patients hyperplasia of megakaryocytes, you can kind of think about this matter that these platelets are either being consumed by something in patient's body, so therefore we have hyperplasia of megakaryocytes, or it can correlate with many other disorders, in fact. Now, one of the most common the main causes of thrombocytopenia is ITP. Now, ITP, what is ITP? ITP is an autoimmune production of immunoglobulin G against platelet antigen. So these immunoglobulins, these IgG, are being formed by plasma cells in the spleen and are being then consumed by macrophages in the spleen. So the site of production of these IgGs is the same as the site of the consumption in the spleen. So these IgGs are being produced by plasma cells in the spleen and then are being also consumed by spleen. Now, it has two types. One of them is acute form. An acute form is classically seen in children, and this causes thrombocytopenia after viral inflammation or an immunization. So, for example, the child has received a vaccine or has undergone a viral infection. They can present with this ITP. Now, there is also chronic form, which is seen in adults and commonly seen in pregnant women who are suffering from a sort of autoimmune disease. Now, this may cause short-lived thrombocytopenia in offspring because these anti-platelet IgG can cross the placenta and can go to the offspring, and that can cause short-lived ITP in that offspring. We have to mind lab findings in ITP is platelet count lower than normal, below 50K, and that's because these platelets are being consumed by macrophages in the spleen. Now, in the patients who has ITP, and we have normal PT and PTT because coagulation cascade is intact and there is nothing happening wrong with the cascade itself, so the PT and PTT is completely normal. We have hyperplasia of megakaryocytes in bone marrow biopsy because, again, these platelets are being consumed with macrophages, so bone marrow needs to compensate for that. Therefore, we have hyperplasia of megakaryocytes there. Now, the options that we have in treatments of these patients is giving IVIG. We are giving these immunoglobulins to the patient treatments. Now I want to show you a picture and describe how it is actually working. Now imagine you want to distract a dog. What it can do is throwing a stick, so it goes and following that sticks and try to find it. So what we're basically doing here is the same. We are sending those macrophages in a spleen after these Igs that we are introducing circulation. So these Igs are distracting macrophages, and they no more consume those platelets. So it's a short-term treatment or short-lived treatment. So if we are handling a patient with severe thrombocytopenia, we can use this treatment. And if you want to have a long-term treatment, we have to perform a splenectomy. And here what we are doing is that we are eliminating source of antibody and site of destruction both together.